are not accepting these vitamin K injections for their neonates. Remember, what was vitamin K for?
Coagulation.
For bleeding. What was that called when they didn't have it? It's the worst name ever. Yeah, the old one was hemorrhagic disease of the newborn. The new one is vitamin K deficient bleeding. That's the saddest name ever. But what kind of bleeding? Is this just like a little scratch? What kind of bleeding was that vitamin K deficient bleeding? Real bad. Like hemorrhagic stroke, bad, and significant GI bleeds, and hemodynamically compromised bleeds. So clinically relevant and things that are happening real time, because again, this was my email this morning. So things to think about as you are going along clinically. As a reminder from where we were and orienting and jumping back in, we had talked about what was normal growth and then what happened when that went awry. Now we were talking about development, and so then today we're talking about what happens when that development doesn't happen. So we talked about some of those normal things, colic, temper tantrums, some of those kind of things. So if we're thinking about that from the other day, it's the wrong one. How many hours of crying a day is needed to make that diagnosis of colic? 3. That's supposed to be the one time you're like, oh, I want to say 2. It's 3. So 3. When is that peak time for colic? Evenings, absolutely. And then what was the peak age that you typically saw? Yeah, 6 weeks in that time frame. What is the one lab that you would standardly get for colic?
Was it?
I see this stuck well. What would be the one lab? Not thyroid. Urinalysis. That is correct. Urinalysis and urine cultures. That's going to be your one standard lab.
There's one thing.
Oh, we didn't talk about that yet. And then back from the genetic stuff, a couple of things. What is your most common preventable developmental delay? Fetal alcohol syndrome, yeah. If you see a double bubble sign on x-ray, you hear double bubble sign, what was that a diagnosis of? Duodenal atresia, correct. And what type of patient do you need to think, ooh, I need to make sure they don't have this underlying genetic condition?
Trisomy
21. If a child has trisomy 21 and you get that screening echocardiogram and it's normal, when do they next need to see cardiology? They don't. Yep. Which one of those abnormalities had that hockey stick crease on the hand?
Turner.
It's in there.
Fetal alcohol, correct.
Yeah.
Fragile X, do those kids have small or large testicles post-puberty? Large testicles, correct. Which of those syndromes has infantile extremity lymphedema? Those big old puffy feet. Not fetal alcohol.
Start with was it K?
Turner syndrome,
Oh.
correct. What causes the infertility in Klinefelters? They make not obstruction, but yes. What process isn't working right? You're just saying male anatomy words. Yes.
Primary.
Remember? Yes, the seminiferous tubules. Good job. What's the cardiac complication you're most worried about in kids with Marfan syndrome? Yep, aortic root dilation. Yep. Got it. Okay. You guys got this. Next week, you'll care about peds. I'm really excited for that. Okay. So abnormal behavior. So now we're not talking about what's normal, we're talking about what's abnormal. And so again, I want you to think through the lens of a lawyer. There is not any of these things that I can say, oh, yep, there's this lab that is absolutely definitive for this. You're looking at the preponderance of the evidence. So does a parent say, this happened one time and I thought it was kind of weird and I wanted to bring it to your attention? Or is this something that's happening all day, every day, for weeks and months that's going on. So when you're looking at that and test taking strategies, if I give you a long period of time and there's a preponderance of the evidence and grandma and mom and teachers and everyone are saying these things, it's probably in this developmental and behavioral realm. So first we got to talk about kids with special needs and how do we even define a child with special needs. So it's a really broad definition and it really encompasses almost 1 in 5 children, so up to about 20% of children that have some sort of need in some realm. So that might be a physical realm, that might be something congenital that was present at birth. This might be educational, behavioral. It can be transient, it can be permanent. So at any given point, kids are going to go in and out of this kind of special needs label. And how is this relevant to the military PA? Well, this was why EFMP was designed. So EFMP was designed for these 1 out of 5 children who are going to need something additional at some point in time. And that's why it needs to get updated all the time, because just because a child needed something at one point doesn't mean they're going to need that forever. Okay? So PCM plays a big role in that. And what is the goal in all of this? If we're identifying children who are special needs and getting them the appropriate help, the goal is to maximize that child's potential. So there are some children that are going to be able to kind of outgrow some of these things or make significant progress with different types of therapy. There's other children that are never going to necessarily be neurotypical, or what we would consider kind of at a normal developmental amount, but our goal then is to maximize this particular child's potential. The families are a second part that we care for. So a reminder that this might be a really interesting diagnosis to you. It's also can be very difficult news for a family, and every family is going to process this grief a little different. So I have 2 kind of quick stories. I had one family that we're having to tell kind of what I would have considered a devastating genetic diagnosis, and this family was just so thankful that they had a diagnosis, that they understood, they were good to go with it and ready to kind of start all of these therapies. Similarly, or I guess completely oppositely, but delivering news that a family, this child had asthma. And so I was thinking, it's just asthma, right? And that this would be totally fine, easy to treat. And the dad just broke down in clinic. He was 5th generation military. And so by me telling him that his kid had asthma, what he heard is my expectation for my child and all of the family plans are no longer a thing, right? So everyone is going to process diagnoses, particularly that you're giving their children, very differently. So just kind of keep that in mind as you're going forward. Why do I tell you all this? Well, because you are coming out as the primary care manager, or the PCM or the PCP, sometimes on the outside, primary care provider. And that is functioning under a model that we call a medical home. So meaning that in a hub and spoke type of relationship, all of that information is going to come back to you as the PCM. So if you've ever wondered to yourself, well, why didn't the GI just go talk to the neurologist? Well, because that's not how the system is made and designed to function. All of those reports and those referrals and those recommendations will go back to the central medical home hub, of which we are training you to be for the military. And you become that central point of management. So what does that mean that you are in charge of doing? Well, that might mean that you're really the coordination and you are facilitating all of that for this child. So you're sending them to specialists, the specialists give their input, you're making sure that the nephrologist and the cardiologists aren't giving complete opposite recommendations, or kind of help sorting that out if they do. A lot of times families they'll nod to the specialist and then they'll come back and say, I have no idea what they were saying. So it can be a lot of education and helping them understand and clarify. Helping understand what do we do with this for the child. And then a second half of that is going to be then how do you get what this children is going to need. So it might not just be a referral. A lot of times as the PCM, especially for special needs children, you're working on how do we modify the home? Do they need a special chair? Do they need a special communication device? A ramp in the house, a bed, something like that. Durable medical equipment is another separate referral, just like anything else. So if you're in your electronic healthcare record and you're thinking, I need to send them to cardiology and they need this special device, I also need to put a referral for durable medical equipment. It's a separate referral for that. What's covered, what's not? So there's a lot of times where I will sometimes throw that in. Hey, for craniosynostosis or for plagiocephaly, a helmet is not covered with TRICARE, right? Your patients are gonna come ask you some of those questions and look to you as the PCM to understand that. Also helping with disability benefits. Do they qualify for respite care? Do they qualify for in-home nursing care? What are those benefits that they are entitled to? When we start looking, we're looking at different realms. So one of the realms we are looking at is if this child is significantly intellectually disabled. So what does that mean? How are we even defining that? So for these kids, we're saying that a typical average IQ, they are meeting 2 standard deviations below that. So 2 of those below that for their developmental stage would say that they have an intellectual disability. So it used to be called mental retardation, no longer a term that we really use anymore. You still might hear that around. That is the same as the diagnosis of intellectual disability. Somebody astutely is going to ask me, well, what happens if they really can't do any of these activities of daily living? How do we just define that? For those children, I think it's on the next slide, who really aren't participating a whole lot in their activities of daily living, right? Have you ever tried to get a 3-year-old to dress themselves? You're like, it's like trying to dress an octopus and nothing is going on correctly. So those children, we term that they're globally developmentally delayed because they are really not at a point where we can say, you are functional at these activities of daily living. So for an example, if you are doing an IQ test and the average is 100, which is considered the average for an IQ, standard deviation being 15, 2 standard deviations away. So if a child is an IQ testing less than 70, they are considered intellectually disabled. Kind of interesting fact, if you ever took the ASVAB and a passing ASVAB score correlates to about a 70 IQ. Just how they determine that. Often see the onset before age 18. Obviously, we're talking about children here specifically. Side note with the ASVAB, so if you have a score less than that, and less than 68, or less than 70, but it's thought that your input, you will actually take more resources than you will be giving to the organization. So that's why they would say you didn't pass. Anyway, side note about how they developed ASVAB. Okay, so under 5 years old, where you're really not functional for those activities of daily living, right? If you have a 2-year-old and you're like, can you brush your teeth? Can you feed yourself? Not well, right? So those kids, we are terming that they are globally developmentally delayed. And really what the precise definition of that is that you have 2 of those realms that we talked about. So remember when we were doing the ages and stages questionnaire, how many realms were there?
5.
5. Do you remember what those realms were?
Oh God.
Any.
Motor?
Motor, gross motor, yep. Gross motor, we got 1.
There we go.
Fine motor, we got 2. Verbal communication, that's 3. The last 2 are really hard. Problem solving and then personal social. Okay, so if you are 2 of those realms, that is considered a global developmental delay under the age of 5. So what are the options then? Once you're over the age of 5, then you can do some of that formalized IQ testing. Well, a lot of those they really will grow out of that. They really do developmentally kind of catch up and grow. Sometimes we do interventions that are going to help with that. So if you were significantly developmentally delayed in the gross motor realm, what kind of referral are you going to send?
Physical therapy?
Correct, physical therapy. What if it was fine motor? Occupational. What if it was speech issues?
Speech therapy.
Oh, who are you sending to first?
Audiology.
Thank you. And then speech therapy.
She got us.
Gotcha. Yeah. Because always hearing and vision can be something. So kind of some of those different options that we will see. It's about 2%. As a reminder, I'm never going to test you on that, but just to see how many you might see. And the majority of those with the diagnosis of intellectually disabled are really going to be in the mild to moderate. So in the 60s category, once you really get into the 40s and 50s, that's a much more rare element. And really, those levels of significant intellectual disability have not changed in the last 100 years. Most of them Most people that have those type of scores for an IQ have a chromosomal or some sort of a genetic abnormality associated with that. Males more than females, just epidemiologically, potentially because of the X chromosome factor in there where they only have one. But good news that some of these things, they were really inborn errors of metabolism or things that we were able to catch on some of these newborn screens. So newborn screens have directly made a difference with especially some of the mild to moderate intellectual disability that we see. A lot of these cases have been identified of what can be causing some of these things. So some things can happen prenatally. So if we think about what has happened in a prenatal instance, so we just talked about one of those teratogens that causes a syndrome. What could that be? Alcohol, sure. So something that could have happened there. Something could have happened during delivery. So you could have a hypoxic ischemic event that is causing something. Could happen postnatally, and something once they're out of the womb, or something genetic could be happening. What we are looking at as providers, yes, it is interesting to see some of these underlying causes, but as the primary care, I care a lot more about some of the modifiable risk factors. So what are things that we can change? Can we change some of the malnutrition, some of the access to health care, education in some of the families around us, different socioeconomic impacts that we as providers can have. So those are some of the modifiable risk factors that we see. And why do we care about those? Because those are where a lot of those mild and moderate intellectually disabilities will come into play, and they have some of those modifiable risk factors. So it's something we can do something about. And as I said, the severe ones typically have a genetic or some sort of chromosomal association with that. So what's your history gonna look like? So you guys just got it already. So maternal history, anything that they were exposed to. Was mom doing drugs? Did she have prenatal care? Did she travel a whole bunch and have some sort of infection? What do we have going on? If we see the torch or the storch infections, what is the S? Syphilis, what's the T? Toxoplasmosis, what's the O? Other, hate that category. Love it also. R? Rubella? C?
Chlamydia?
CMV?
CMV.
Yep, and H. Herpes, correct. Yes.
We have chlamydia on the brain with the women's
The
health.
developmental history. So what would you be a little bit more concerned about potentially? You've seen this child, they've always been behind and you've had a close eye on them, or the child that was really doing fine and suddenly something is dropped.
Nutrition?
Right? Suddenly something changed, that's gonna be a big red flag. Then I think, what changed? Is there lead poisoning? Are they anemic? What has happened at home? Something like that. Family history. Hearing and vision screening. So when do we do that hearing screening?
Before 6 months?
Before.
Or 6 weeks?
Before you gotta get them to definitive care at 3 months. But when do we do that first screening? Right away.
Right away.
24 hours. 24 hours of life. Yep. When can you do that first vision screen that you were talking about?
Oh, that was 6 months?
6
Okay.
months. Validated down to 6 months. Yep. When we're looking at some of these exams, you want to know, is there any kind of syndrome that you're looking at? So way back from that very first lecture where we said potentially you might have a smaller head, you might have those low set ears, posteriorly rotated ears, different faces, facial features, some of those things. Or do you have failure to thrive or that growth faltering? Some things to think about for, is there an underlying reason for this? If there's a treatable cause, certainly treat that, right? Hypothyroidism being the classic example, lead poisoning and hypothyroid. So if I give you something like that and you can treat it, please treat it, right, on a test question. If you're looking at physical and laboratory evaluation, so things that I always consider, do I need to do a urinalysis? So people are always like, a urinalysis, a UTI? Well, no, not in my world. So in my world, looking at, do you have an inborn error of metabolism where you can't break down some sort of organic acid or amino acid, and so you are peeing out those waste products that never got broken down, right? Those shouldn't be there. So a urinalysis to see, do you have some of these unbroken down things that would point to an inborn error of metabolism? For that, I can also go back and look at that newborn screen. So a couple of things. Did they get one? Did anyone ever look at it? Right? So if there's a test question that says, the child was born at home in a bathtub, right? That's some way that myself or someone in front of the pants is trying to tell you, hey, they didn't get that standard newborn care. So things to think about and look at. Always hypothyroidism, or something to do with your metabolism there. And then your chromosomal analysis. Do you have the right number? So what's another word for chromosomal analysis? Karyotype. Good. Considering a referral to developmental pediatrics. Remember, this is a long one. They see patients, 1 to 2 patients a day. So this could sometimes take several months. And so oftentimes, while I'm waiting for that, I'm sending them to every therapy I have under the sun. So PT, OT, speech therapy, horse therapy, play therapy, vision therapy, you name it. They have all kinds of therapies out there. Every single place in the United States that has a public school district, which is all of them, will have a school evaluation. They have an early intervention program for ages 3 and younger. Above the age of 3, they will do school testing for intellectual disabilities or any kind of learning disabilities. We can also do different testing in clinics, so the Denver screener is something that you might hear about. These are the common mistakes that I will hear people say, that just the pediatrician soul in me is crushed every time I hear them. So hopefully you will never be the PAs that say any of these things, right? So if I say the child does not look abnormal, they look normal, right? That is the difference, and why I really want you to understand that there is growth and there is development. You maybe have grown just fine, but that doesn't say anything about the functionality and what you can or cannot do. They can walk, so they're not delayed, right? Remember, that's why we said there's a lot of realms. There's all 5 realms. So maybe you're fine in gross motor, that really doesn't say anything else about your personal, social, or communication, or fine motor, just because you can walk. Or the child is too young to test for delays. So way back a couple lectures ago, those ages and stages questionnaire. Do you remember how young I could test down to for the ages and stages developmental screening?
Newborn?
1 month.
1 month.
So I can go down to 1 month, right? And then if we said too young to test for delays, well, when did we check for hearing? Newborn.
Newborn.
Right? So I don't really know what people are meaning when they say they're too young, because I can do something in 24 hours. So earlier we can recognize this, earlier we can intervene, but also the earlier it's recognized, oftentimes the more severe this is. So that was intellectual disability. See that. Flipping, now we're talking about cerebral palsy. So this is kind of, in some ways, the exact opposite. So this has to do with motor functioning. So the definition looks a little funny at first, so we're going to talk about this. It's a non-progressive, but often changing motor impairment. So what does that actually mean? Because those look like they're saying opposite things. So non-progressive, meaning that it was a one-time insult. Something happened, one time. Did they have a birth accident? Was there a car accident? A drowning incident? Something that happened, a one-time insult, that because the child is growing and developing, it ends up looking very changing, because this child is growing and developing. So, non-progressive, but changing motor impairment. Okay? So it's just that one realm again, in your gross motor. Can be secondary to some sort of lesions in the brain, or can be secondary to some sort of hypoxic hit that they had, postnatally, prenatally, or some of the combination thereof. Can see this depending on where the brain took that hit. You can see all kinds of different neurologic outcomes. So they might have some epilepsy or seizures associated with that, depending on what part. Might have sensory issues, some cognition or speech issues, motor functioning as well. Again, epidemiologically, so relatively rare compared to some of the other things that we've seen. You see it more in premature or twins, more likely that those are high-risk births or high-risk pregnancies. Also, if they were not in utero, something made them deliver early, so was it an hypoxic event? Some congenital malformation and kernicterus. Ooh, we've heard of kernicterus. What was kernicterus? Yep. Bilirubin, so you have hyperbilirubinemia, right? So the thing that we should never see, and that I'm going to ask you a question on, because it's bilirubin. It's very important. Some of those maternal infections, you guys already nailed those with the torch infections particularly, so that could be something that you see. And we've increased a prevalence, so if you're just looking at kind of these epidemiologic studies, we've seen this slightly increase as premature infants have survived more. So the more premature and the younger and younger and younger that we're able to resuscitate, the more we have seen some of this. So the prevalence has increased. What about that postnatal? So not in that prenatal period at all. So it's more rare, so relatively rare, 10%, but some of those things that could happen. You had meningitis, so it's gonna be one of those kind of devastating outcomes that you can sometimes see from this, particularly bacterial meningitis. That's part of block 2 that we'll talk about. Any kind of head injury. So this actually could be part of particularly relevant today. If there was a head injury or a bleeding issue, potentially didn't get vitamin K, that could be a cause of that underlying. Could be a cause of a stroke in a child as well. Could have been near drowning or a near fatal drowning accident. Certainly abuse, when we talk about that lecture on Monday. So the one lecture, Halverson was talking about, he's like, you'll have all of our attention on Monday. I'm like, it's child abuse. Like, so sad. But at least I'll get their attention. Or some sort of trauma. Trauma is always on that differential. Your diagnosis, there is no lab that I can give, so it is a preponderance of the evidence again. Most of the time in those first year and a half of life, and this is where those milestones are gonna help. So back a couple of lectures ago, I said star this slide on the red flags of development. So that red flag is going to come back here as something that can haunt you. So those milestones will help. So if you have a child who at the 3 to 6 month mark is doing some things that you would not expect them. So they could be looking like they're underdeveloped or looking like they're overdeveloped. So this could be a child that comes in whose head is still lagging at 3 months. Significant red flag, they're hypotonic. Alternatively, you could have a child where the parents come in, they tell you the child's rolling at 1 month. You're like, just like once? And they're like, nope, rolling all the time. At that point, I'm actually concerned that there's hypertonicity and the child's legs are scissoring over and crossing each other and it's flipping the child. So that could be something where it looks like they have advanced development, but it's really the hypertonicity. Another one we had talked about was dominant handedness, right? So if you have one hand that isn't being used for anything and they preferentially will use one hand before the age of 18 months, another one of those red flags connecting that previous lecture. What if you had a 6-month-old? Can't sit up, can't roll, can't do any of those things. Again, those red flags of development will come back. The caveat I will give you for the crawling and the walking is that truly the developmental milestone is, are you mobile and can you figure that out? So there's a difference in the child that does those weird army crawls or like kind of does the one-sided crawl, then I can't use a side of my body, so I am only pulling myself with one side. So a little bit different, something to pay attention to if you're in clinic with them. Always hearing and vision, those UA screening again for some of those organic or amino acids. Thinking about, do I need to do a genetics referral? And then is there something from a neurologic standpoint, seizures, contractures, that I need to have neurology on board to help me manage? As a reminder, when we are communicating provider to provider, you can't just tell somebody that like their hand doesn't work or it looks kind of funny or they don't use half their side, right? So we're using our provider words. We're saying hemiparesis. I said that child's not using half their bodies. If I'm saying they have hemiparesis on the right, I'm saying they're not using their right arm or their right leg. So side versus the other. Versus diplegia, I'm looking at a superior and inferior. So they're not using both legs, or in a more rare case, they're not using both arms. Probably heard often used of quadriplegia. We're not using any of the limbs, both sides. And then the different types of movement. So are you trying to describe how this kid's cerebral palsy is presenting? So an athetosis is going to be a writhing kind of continuous movement versus a chorea that is a rhythmic and more of a jerky type movement. So the neurologist is just asking you and you're like, I don't know, one side just kind of moves funny, right? It's very different than if you say this 18-month-old child has hemiparesis on the right side and has chorea-like movements, right? That's much more helpful to your specialist that you're talking to. So what's my goal? My goal is to make sure that this child meets their maximal potential both in functionality and in their independence of their ADLs. So a lot of times, and you're gonna see this pop up more and more throughout your careers, you're gonna have multidisciplinary clinics. So if you're thinking about this child with cerebral palsy who sees occupational therapy and speech therapy and physical therapy and genetics and neurology and the pediatrician and it's easier oftentimes, and you will see a cerebral palsy day in the clinic, or a trisomy 21 day, or a diabetes type 1 day, where all the multidisciplinary specialists will meet together on that same day to take care of the patient so that they come once instead of coming 14 times in a month. Adults are starting to do this more, so their PEDS is leading the way. So you'll see this sometimes with like a hepatitis C clinic, for example, or an HIV clinic, things like that. Hooking up these families with different support groups, all the different therapies, can be super helpful for that.
And are those multidisciplinary days, like, does command take charge and decide when those are, or what?
Most of the time the providers will. So, like the Department of Peds here, they will say, hey, you know, we are seeing an increased population of cystic fibrosis patients. So, you know, I'm seeing them, but you haven't seen them since the last time I saw them. And it's really a provider-led thing, not command. Okay, on to autism. Okay, so we said intellectual disability and cerebral palsy. Now on to autism. So this one, these realms that we're specifically talking about, oftentimes their gross motor is just fine. Their fine motor might even be fine. These particular realms are in the communication, personal, social, and often some of the problem-solving ones. So and what I need you guys to think about for purposes of this class is when you think of the typical type of autism. Okay, so they're kind of the standard or classic type where there's much difficulty with expressive language and some of the stereotypic behaviors. So that might mean some of the hand flapping, toe walking, inability to communicate some of their thoughts. So you might hear more of an echolalia. So they're saying words, but they're not really their own thoughts. They're more of parroting back to what the parent or caregiver is saying. The biggest thing that we'll also see is that they're very, very routine and complete inflexibility to things. And so this might mean every day we do this pattern and we have this for breakfast and we go to the park at this time, and now if we don't go to the park because it's raining, the day is ruined, right? It's not a 5 minutes that's ruined, the day is ruined. So this inflexible rigidity is some of the kind of classic pattern of this. The other thing I think I've seen in every single board prep question is a child lining up their toys, lining up their cars. So if you see that, that should be a flag immediately. They're trying to tell you about autism. The other biggest one I think that's clinically relevant is that they're oftentimes hyper or hyposensitive to things. So sensory is a huge issue. I had one child who could not handle any kind of elastic on pants or socks or hair ties or anything. Like the elastic band, absolute no. Another kid that was like that crushed velvet or like corduroy would only wear that. And so very highly sensory driven. So hyper or hypo. We'll talk about why that matters for some other things coming up. Often these present in very early signs. So oftentimes parents looking back, they'll say, oh, I should have seen this by, you know, it was evident because they weren't talking, they weren't looking at me in the eye, they weren't doing some of those things early on. And all of these symptoms have to cause some sort of clinical impairment, right? So there's always going to be times where kids will not look at you in the eye or will not respond. But is there some sort of impairment where they're not socially developing in these areas of functioning? Can't be explained by intellectual disability. So this is one of those areas where your developmental pediatrician is really gonna help you tease out, is this intellectual disability, is this autism, is this something else? Not a global developmental delay. Things about autism. There is some sort of genetic component, we just don't know why fully yet. We talked about one of the known genetic causes the other day. What was that known genetic cause? Fragile X. Yep, so it's one of your known genetic causes. Thank you, you guys got that. I just look crazy up here doing like random positions. This is what I do for y'all.
You join a test now, do that.
And really thought to have some sort of disruption in the neuronal connectivity. So they might all be there, but they're not connected appropriately. Really when they do retroactive and prospective studies, both sides, vaccines do not have really any correlation, so time and time again. Some of the environmental things that we do see, so these are correlations, not causations, but when you see a higher prevalence, things that we do see are increasing both maternal and paternal ages. So as the rate and as the age of first-time parents has increased, seeing that as a correlation. Preterm births, as those get younger, you see a higher correlation. As moms get bigger, maternal obesity, see a correlation with that. Short interval pregnancy, how short is a short interval pregnancy? Within a year.
A year?
Classic Irish twins, so 12 months. And then your torch infections, your prenatal infections. About 1% of the population, an equal opportunity offender across racial and ethnic groups. And in the literature now, your current textbook is going to say there's a higher male to female predominance. That's this classic type that we are thinking of. So this classic kind of well-known, a little bit easier to see is male to female. What I think your next iteration will be and what the data will pan out to be, this is just Klein now, is that you will see an atypical pattern in female and it will be closer to a 50-50. But for now, more of a male predominance, just because the females look often very different. You know there's some sort of genetics because your siblings and twins, you see an increased risk. And then knowing that there is some sort of overlap with intellectual disability. So just some of those things to keep in your mind for the epidemiology of it. What goes with this also? So sometimes anxiety, sometimes ADHD, mood disorders certainly can overlap with this. What you see oftentimes is a lot of sleep problems. So that's one to start. So sleep and then feeding are really toileting issues. The sleep issues, if your neurons are not connected correctly, that makes sense that it's gonna have a hard time shutting it down and sleeping at night, kind of initiating that sleep process. Thought to be maybe part of melatonin secretion, some of that neuronal connectivity, but sleep is a huge issue for these kids. So is it really that they have ADHD or is it that they're sleepy, right? So chicken or egg kind of question there. The sensory issues, feeding becomes a huge issue, right? How many of you have toddlers in here or have been around a toddler, nieces, nephews? How well does trying to feed them all kinds of things work, right? They have like 4 things that they want to eat, and if you do not give them those 4 things, it's like trying to negotiate with all kinds of things, right? So, Maggie said it, not me. But this becomes even more restrictive. So one particular patient I had, we were trying to figure out how to get anything down this kid because he was at risk for scurvy because all he would eat was potatoes, right? So if he wouldn't take anything else to include vitamins, how do we get something down this kid so that he doesn't end up with a vitamin D deficiency or truly scurvy in like 2019? Toileting issues, same thing. Is this a chicken or egg? So sometimes it's from the restricted and very limited diet. Sometimes the sensory feelings of defecation are very disruptive and cause a significant distress to this child. So toilet training and chronic constipation go with kids with autism almost all the time. So if you're the PCM of a child with autism, particularly sleep, what's their nutrition status, and then do they have some chronic constipation going on? Very important. Your son. What is your screening tool for autism? MCHAT. Yep, modified checklists. Autism in toddlers. So your MCHAT. When do you do that?
When they're toddlers?
Yep, 18 and 24 months. And there were those 3 red flag questions. It's 20 questions, but 3 of them were the red flag questions. Does anyone remember what the 3 red flag questions were? Hearing, yes. Have you thought your child was deaf? So that was question number 1. Question number 2. Yep, do you make funny movements with your hands around your eyes? Those stereotypic movements, correct. Question number 3, what was that one? What about noises?
Sensory sensitivity?
Yes, are you significantly distressed by everyday or loud noises, right? So the vacuum cleaner goes and the day is ruined, right? So those type of things. So you guys got it. So 18, 24 months, 3 red flag questions. This is a screening tool again, right? So if they say, yeah, I do funny hand movements and I think they're deaf, you're not like, bam, autism, nailed it, right? No, it's a screening tool. But then they will go on to a definitive diagnosis with a developmental pediatrician for formal testing called ADOS, A-D-O-S. For primary treatment, so very individualized. So these kids have different underlying reasons and different presentations. So very individualized therapy. I don't know why I haven't starred and underlined and highlighted this, so I'll have you do it for me. But ABA, Applied Behavioral Analysis. Star, underline, highlight that one. That is the particular type of therapy that children with autism need. What is that, you ask? Well, if you are in a specific realm where you do not have that development correctly, so personal, social, communication, and problem solving, this type of therapy functionally teaches you that. How do you look someone in the eye? How do you learn to shake someone's hand and say, my name is Lindsay? How do you learn to do that if it doesn't happen naturally and developmentally? So that's what that type of therapy is. Has anyone ever taken a child or their child or anyone to speech therapy? How long was the appointment?
It was about 30, 45 minutes.
Yeah, 30 minutes tops. Yep, real short. Children have very short attention spans. How much ABA therapy is a child prescribed a week?
30, 45 minutes?
Yeah, like 30 to 40 hours a week.
Oh.
So it's a full-time job for
Never
these
mind.
kids. 15 hours is about the least I've seen. Most of them are between 20 and 40 hours. So this becomes their full-time job of what they're doing all day, every day. It's a very expensive therapy too, so the military makes you fill out a lot of paperwork so that they will pay for this. But this is one of the causes and conditions why people will join the military, because TRICARE covers ABA therapy. Nutritional counseling. No, let's not have any scurvy in 2026 in the United States. So developmental pediatrics. These are the kids that you actually are going to send to psychiatry if they need it, right? This is not going to be when we talk about ADHD, we're talking about some kind of quote unquote run-of-the-mill anxiety. These are not the kids you're sending to pediatric psychiatry. It's the kids with complicated mood disorders who have an underlying diagnosis of autism. Right? That's when you want your ped psychiatry on board. All your therapies, special ed, having school involved. We'll talk about what school's going to do in a little bit. But big takeaway from this slide, make sure it's highlighted, underlined, starred, is ABA therapy. Things for you to know as a provider. So it's called complementary and alternative medicine. Families will call it CAM therapy. And so if they're saying, I do CAM, they're basically saying, I don't necessarily always want to do what is in the literature as evidence-based. I want to do some other kind of therapies. What I would encourage you to do as a provider is listen to those families, encourage and support where you can, try to change one thing at a time, and know what's harmful, right? If a family wants to go to town with all kinds of essential oils, do it, right? All the eucalyptus oil out there, we can support that. They're going to do high-dose vitamins and chelation therapy and things that could hurt a child. That's where you want to save your input for, okay? If they're gonna say, I wanna do these restrictive diets and do a probiotic and do and they start 5 things at once, now they've kind of committed to themselves to that if any of them work. So a lot of times encouraging one at a time, being familiar with what's out there. Provider to provider, you will also hear integrative medicine clinics popping up. So if you hear about integrative medicine, they're integrating traditional medicine with CAM. And so those are what your integrative clinics are. Takes us to ADHD. This is one of my favorites. Before we start ADHD, let's take a break. Let's do 10 minutes and we'll come back and jump in. It's like such a bad move on my part. So we're talking about attention deficit hyperactivity. And remember, we're talking about kids at this point. So our number one most prevalent, and I will tell you what the book says and I'll tell you what I think about that. Again, you're gonna see more of a male to female. However, I think also we will see a very similar pattern in this one. So when we are looking at more hyperactivity, we see that in males. We're seeing more inattentive, we'll see that more in females. Who's going to get more attention as a child? The little boy who's running around the room and disturbing everyone, or the little girl who's looking off into space in La La Land, right? The little boy is going to get much more attention and much more intervention, so it looks like the prevalence is higher. So again, I think you will see this kind of even out over time. A lot of these symptoms will persist into adulthood, but here is where the caveat is. All of these things, this is ADHD, if you are asking them to do something in a normal environment at an expected developmental age. So my example I will give you is IPAP. This is not normal, right? It is not normal to take adults, put them in the same room that is either really hot or really cold, and ask them to pay attention and passively absorb things for 8 hours a day for 16 months. It's not a normal expectation, and then to think that you wouldn't have some level of hyperactivity or inattention. That would be insane. So the same for children. Are we asking them to do something that is not normal or developmentally inappropriate? So if you get a consult and a child that says, man, our son just won't sit still in kindergarten, and you go through the timeline and they're asking these 5-year-olds to sit in the chair for 4 hours with no breaks, well, that's not something that should be expected developmentally out of this child. Okay? So is it appropriate developmentally or at a human level of what we're asking somebody to do? So that is my theory that 100% of you in this room will look at every single symptom for inattention and hyperactivity and say yes, right? Because we've put you in a false environment with this. So your symptoms of inattention, see how many you have. Does everyone have all 9? Failing to pay close attention, not listening, failing to follow through, sustaining attention, difficulty organizing, avoiding or disliking activities that require sustained mental effort, frequently losing things, distracted, forgetful. So if anyone in this room doesn't have a 9 out of 9 for that, you're like a transformer or something, I don't know.
Where's
Your
my Ritalin
symptoms of
prescription?
hyperactivity, fidgeting, restless, running, leaving seat, feeling like you're driven by a motor, talking excessively, all of those, some of the impulsivity as well. So you can see that, again, when you are looking at this, 2 things. Is it the preponderance of the evidence? So is this something a child was doing after they were cooped up in a car on a road trip? So is it, or versus all the time? And then are they in an environment that they would developmentally be able to do that at an expected age? If you're under 16, you need 6 of them in one of the categories. If you're older than that, you need 5 in one of the categories. Always the symptoms are starting before 12, so it's something to look at. So if you are interviewing somebody, especially an adult who's older, and they're like, nah, I always did fine, and now I don't, something to think about. Is there secondary gain? Are they using this performing enhancing? Are they selling these? Just things to think about. There has to be some sort of impairment too, right? So would argue that even in IPAP, you might be feeling all of these symptoms and you're still getting 90s on your tests. Is there really impairments? There might be, there might not be. So you're looking, is there functional impairment in multiple settings? You need 2 settings for children. And you have to make sure other mental disorders are excluded. So when you're looking at this history, so things to think about. If you see it in school only, so school only, but home is just fine. I start thinking, can they not see the board? Can they not hear the teacher? Are they getting bullied? Are they dyslexic? Is there something else at school going on? What about if it's the other way? School, they're little angels. But what's happening at home? Is there some discipline issues? Is there abuse? Has there been changes in the structures? Divorce, death, deployments, something like that. So thinking, is it multiple settings? You'll get some families that will say, well, we homeschool, so we can't do the school environment. Okay. Do you go to a church group? Do you do gymnastics? Do you have a soccer coach? Do you have Cub Scouts? Where else are you that you could look at these multiple settings? Is there a family history of this? One of my favorite stories was a mom who brought in her daughter for an ADHD evaluation. The girl was maybe 7, and she was sitting there coloring her coloring book nicely. Like, she was just coloring her coloring book. And the mom was telling me she thinks that her daughter had ADHD, and she's like got papers flying and stuff was all over the room, and she was just a hot mess. And so you had to say, ma'am, I don't think it's the 7-year-old. I think it's you, right? So what kind of family history, and is it really the child, or do you have a guardian or parent who might be having an issue? You can use a Connors, but standardly, so circle, highlight, star this one, the Vanderbilt rating scale is what we're going to be using. So it's 2 different ones from 2 different settings. So you need parent and guardian, so 2 for parents, somebody who's a primary caregiver around a child, and then somebody else in your other settings. So the Vanderbilts are going to look like, so they're going to ask all of those checklist questions. They're also going to screen for some other comorbid issues, things that we will look at. Things that I should have not put this picture on there, so if you look very closely and you zoom, you do your little zoom thing that you do. This one says Vanderbilt follow-up assessment, so just one pitch there is that there are initial ones and then follow-up assessments. So clearly if you're diagnosing somebody, do not use a follow-up assessment, use your initial. Poor picture on my part there, but just so that you've now seen that. What are the things that these Vanderbilts going to look at? So they will screen for some other psychiatric conditions. So we'll have screening questions for oppositional defiant disorder, conduct disorder, and some anxiety, depression type things. Your medical conditions. So how many of you sleep like a little angel at night? Like 5 of you, just so lucky. Right? If the rest of us that can't sleep all that well, if you're tired during the day, you're going to be doing things to try to keep yourself awake. And that can sometimes look like ADHD in a kid. So for a medical condition, when you're screening for that and asking a history, really getting a good sleep history. Is this child able to fall asleep, stay asleep, appropriate amount of hours? Is there a sleeping issue? Do they have OSA? Do they have a TV on in their room that's going all night? Is there a seizure disorder? So everyone do an absent seizure. Good job. You all did it really well, right? Is this child actually having absent seizures and they're having multiple seizures in a minute? You're going to look easily distracted if that is the case. So is this actually a seizure disorder that they have? Certainly if they're older kids, is there a substance use and a withdrawal potentially? Your thyroid, because thyroid can be anything. Your lead toxicity, certainly, that would be if it's sudden. So if you had a sudden onset change and they didn't have this before, something to think about. Your genetic disorders, so we talked about Fragile X being one of the things. Do you remember what 22q 11.2 was? What syndrome was that? I won't ask that on the test, but it's back in the slides.
So one that sounds similar to another one. I remember there's 2.
George.
The George.
The George syndrome. That was the one. Midline structures. Catch 22. Hypocalcemia. NF1, we'll talk about that in block 3. And then some of your psychological factors. Again, are you being bullied? Is there something wrong at home? Or is there abuse? Food insecurity? All kinds of things like that. Okay, so your first line treatment. So again, there has to be some level of impairment. So all of you guys in this room you have treated yourself with some of these behavioral modifications. You've all compensated and figured out how to cope. and looking around, looking at the pen tapping, the foot tapping, the coffee drinking, the fidget spinning, the standing up, and the swaying, right? We've all learned how to compensate for some of these symptoms that you are seeing. So first line management, and look at the question. So if I ask you first line management, it's very different than first line medication management. So first line management for this is your behavioral modifications, behavioral management. How can we help them cope? What kind of tools can we give? What kind of adaptations in the learning environment can we do? What kind of structure or routine? Maybe that means you have a better sleep hygiene so that they're well rested and then don't have to cope as much during the day. So that's gonna be first thing. Optimizing educational, so maybe not having a room that's 80 degrees, right? Or a room that's 54 degrees. That could help. I hope the Army can hear me. And then are there any other kind of social or school trainings we could help with this child? So first line treatment for ADHD is going to be behavioral. Now your first line medication treatment is going to be your stimulant medications. So in children, we want things to sound less like methamphetamine. Okay, so your first line, even on that, is methylphenidate compared to your amphetamines. Okay, so that are still the first line, but methylphenidate is going to be first. They come in all sorts of things. So if you're thinking, I can't give this to a child, they come in patch form, they come in liquid form, they come in sublingual form, they come in any kind of form. So you can give these down to the age of 4. Start low, go slow. Children will very quickly get to the point where the side effects are worse than the benefits that they're going to get. So lower doses and finding what is actually beneficial is the name of the game there. If another family did very poorly with the medication or did very well with the medication, something to consider as a provider. And then some of your non-stimulants. So these are things to think not first line, but more of a second line, or if a family says we really don't want a stimulant medication, or we tried that, we really don't want that anymore, atomoxetine or Strattera, your norepinephrine or reuptake inhibitor is kind of your go-to for that. That bottom list of your alpha agonists, those are adjuncts. So this is not something that I would ever say, I'm going to treat someone's ADHD with clonidine, but this would going to be for some of those side effects or things that happen. So I had a child with something called Leigh syndrome, horrendous ADHD. So had to be on very, very high dosing of stimulant medication to stay functional, but that brought out some tics and some side effects. And so we were using clonidine to help with some of the side effects, but not to treat the ADHD. So those are adjunct treatments and medications. Never going to be first line. Because these are Schedule II medication, meaning you have to have a DEA number to prescribe these. These are not for the faint of heart. Because of that, we have to see these kids for follow-up for twofold reasons. One, because these are well controlled by DEA, but two, because they're very powerful medications and children are in that growth and development, we need to check a couple of things. I need to check, is this kid eating? Is this kid growing? And what is this kid's vital signs doing, particularly heart rate and blood pressure? So that's why I need to see them face to face every 3 months to make sure they're doing okay. So if you've seen adult practices where someone gets on the phone, they're like, you're still alive, proof of life, here's 3 more months. A little bit different in kids. Are you eating? Are you sleeping? Are you growing? Are your vital signs okay? So these stimulant medications, the first 2, they're bolded for a reason. These are the these are the 2 highest and most frequent side effects that we see. So if you're getting a stimulant medication and you are constantly on go, you're not going to feel very hungry. So you have this appetite suppression. Well, that's a problem if you're not a fully functioning adult who's like, ooh, I feel a little slim and trim today. If this is you as a child trying to grow and you don't have an appetite, a lot of times you see growth faltering start. So we're looking at growth charts. Number 1 to see, is that trajectory slowed down or have you lost weight? These kids should never lose weight. So appetite is going to be one thing. And then sleep. Are they falling asleep? Are they staying asleep? Did we just exacerbate a problem? The other ones you see at higher doses often, so heart palpitations, some hypertension, If you see those higher doses, you can sometimes elicit a tic that will start to come on. And then the nausea and headache have asterisks for a particular reason. Those often are at the onset. So when you very first start the medication, because you're kind of in that go mode, a lot of these children will say they feel a little nauseous or they feel like they have a headache. That should go away in a week to 2 weeks. So if it's lasting longer, several weeks or months, you should probably think about a different diagnosis or a different medication because they are having outweighed side effects. Comorbidities. So a lot of times these will improve after ADHD is treated or vice versa. So if you had a sleeping disorder, you had your tonsils removed because you had OSA, suddenly now you're sleeping and your ADHD symptoms got better. Or maybe you were a really anxious kid at school, but it's because you can't pay attention. So we treat your ADHD and now your anxiety got better as well. So sometimes it's hard to parse out, but oftentimes treating one thing in a child will end up improving some of those comorbid conditions that they have. The follow-up Vanderbilt that I put astutely in the wrong place is there to help assess, have we actually progressed or are we just medicating you and zombifying you? Really kind of seeing where that risk and benefit is. And then a plug for your IEP and 504 plans. So these are two different educational plans that I didn't hear at all about in medical school and got out to the field and suddenly I was being asked to do these things. So I would at least want you, maybe it'll be in like the cobwebs of your mind someday. And you'll be like, I think this crazy lady said something about this, and you can find it in your brain. So an IEP is an individualized education program or sometimes plan statewide. And that looks at curriculum modifications. I'll tell you what I mean by that in a minute. A 504 plan, federal law, that looks at adaptations in school. So what does that functionally mean? So if I said, I'm going to adapt IPAP to make it easier for you. You still have to take all of the PEDS tests. You still have to come to all of the lectures. But for your tests, you can take it in a room that's a comfortable temperature. And you can have 2 hours to do it, and you can use, you can have music playing, and you can be by yourself, right? It doesn't have to be at 8 in the morning. You could do it after lunch, right? So I've adapted the same curriculum. What an IEP does is it modifies it. It says, I'm still going to give you a degree from IPAP, but you only have to take one PEDS test. And you don't have to take any women's health tests, and you never have to see Dr. Evans again. So that second half of urology is just done, right? I've modified the curriculum. And so those are two separate things. I've either adapted the environment or I've modified the curriculum. Both of them require a written request to the school to do. So there was a podcast I listened to about a family that had been fighting for years to get an IEP or a 504, and they'd just been talking to the principal, never put it in writing. So they had to hire a very expensive lawyer to put it on a memo. So in writing, and then they have 60 days. The school will have 60 days to produce one of these depending on their testing. So, plug for that, modification versus adaptation. A couple of other ones, just because we talked about the screening form. So on that Vanderbilt screening form, it would look at oppositional defiance. This is where I need you to be that lawyer to look at the preponderance of the evidence. If you've ever been around a child or another human being, you will sometimes see that people are angry and irritable and argumentative. But is that what this child is all the time? Are they vindictive? Is it anything that you say for weeks, months, that they're going to go and be very defiant against? Again, more females than males for this. There's very specific DSM criteria, but something that it is screened for on those Vanderbilt forms to make sure that you're not giving a child with ODD, with stimulant medication, that can sometimes make it worse. Contrast this with conduct disorder. Pull that way back from sophomore semester. Was that with McCampbell, or did you guys have, was with McCampbell? With McCampbell, you're talking about what this conduct disorder can someday, once they're 18, be solidified and be considered antisocial personality disorder. So conduct disorder is the far extreme of that oppositional defiant, where you've not just become angry and defiant and vindictive, you're starting to cross over into other people's basic rights. So the classic board question that I have seen every single time is that they are hurting animals. So they're hurting cats, they're hurting puppies, they're destroying property, something that's really destructive, and under the age of 18. again, is going to be considered conduct disorder well past that oppositional defiance. So another thing that is screened for on those Vanderbilt forms. Those two, so particularly if you see ODD and you see oppositional or conduct disorder, those are another thing that is going to be at pediatric psychiatry. So we talked about autism plus things. This would be another indication to send that. So not your generalized anxiety, not your run-of-the-mill ADHD, but these are the kiddos that need true pediatric psychiatry. School is going to help you out again with those IEPs or your 504 plans. What do we need to get the parents? Do they need some parenting classes? Do they need additional resources to help manage this kid at home and at school? What medications are going to be helpful versus what's going to be harmful? So some are going to be really helpful, some are going to make some of the symptoms worse. There's a lot in there that are going to be off-label, so not FDA approved for that particular thing, but sometimes will get used. It's kind of an abrupt ending to that one, but that's the end of that lecture. To that, an 8-year-old having trouble in school undergoes some educational testing. She's found to be dyslexic, and she requires a quiet testing space and is allowed some extra time to test. Does she need a 504 or an IEP?
504.
504, correct. Sweet. We have a little bit of time. Let's start the next one. I know you're all so excited. Lie to me.
Yay.
Thank you. We won't go full time. Do you need a wiggle movement, a wiggle moment? Take 5 while I figure out where this is. We'll do about 20. Are going to be adolescent and then child abuse. And so we'll get through adolescent. So I'm trying to do this so we can get you guys out tomorrow to be able to study longer for women's health that you're going to be just fine on. All of your tasks from your syllabus that I'm sure all of you read in depth. The other part that we will cover in this is some of your sports medicine stuff, so things like your sports physicals, some of the stuff that we will see with that. So, in general, when you are looking at an adolescent, think of them as a human transformer, right? So they are literally becoming an adult in front of you. And so you're really having to go from, I'm treating this patient like a small child where the guardian is doing all of the talking and all of the history providing, to an adult where if you brought your mom with you to an appointment, that might be a little weird, right? So we got to make that transition. And that adolescent time frame is when we're doing that. So confidentiality is going to be one of the biggest things that is hit for adolescents, is that letting them know that what you say stays between the two of you. So when you say that big word, a lot of adolescents, if you say everything you say is confidential, they will just nod their head. So thinking of a way to make sure they understand what confidentiality means and what the limits of that are. So if you say everything you say, I can't tell your parents, but then you go write it down in the medical record and the parents get the medical records, something to think about, right? So you have limited confidentiality. The other exceptions to that are, I cannot keep this confidential if you tell me you're going to harm yourself, if you're going to harm somebody else, or if there is abuse, sexual or physical abuse going on. So those are the things that I have to break confidentiality for. So please know those ones. That is when you have to break confidentiality for. All of this will account for your developmental age. So I typically will start some of these adolescent interviews about age 11, depending on how much or little development is going on. But about 11, kind of ramping them up into 12. And then in those adolescent years. I'm going to talk to an 11-year-old very differently than I'm going to talk to a 17-year-old. Worlds apart, right? So accounting for that developmental stage. Finding something where there's some level of rapport can be very, very helpful. So we have to take, like I said, that individual from a very concrete stage. So we said that several lectures ago, that children really don't have that abstract thinking, right? If you put them in timeout and you're like, think about what you did, they're not thinking about what they did, they're just cooling off. Similarly, as they get a little bit older, very concrete thinking. So those 10 to 14-year-olds, black and white thinking. Today is all that matters. What my friends think of me right now is the end all be all. it is just yes, no, so concrete thinking. Contrast that when they're young adults, and they have some of that abstract thought, they're looking at more of some of this future planning. What am I going to do? Who do I want to be? What kind of partner do I want to have? And then your highest risk is right in that interim, where they're going from concrete to abstract thinking, high risk taking. They're testing those limits, they're looking for autonomy, and they're experimenting with a bunch of different ideas. So from going from concrete to abstract, managing those and figuring out very quickly in an appointment where they are kind of on that scale. This one is, start of this slide. Just study this one. So when you're interviewing an adolescent, confidentiality and discussing that with them, and also separating them from from whoever they came with is the recommendation, and not to just get them alone so you can have weird conversations with a patient. That's weird. The reasoning behind it is that you again are going from a child to a functioning adult. So splitting up some of that time where you're getting history and input from the parent, and you're also teaching the adolescent to have a discussion and give some of their own medical history and medical input. So that's what some of the separated time from a parent or guardian is about. A lot of parents are very uncomfortable with that. And so I just tell them, very frankly, everything I'm gonna ask and everything we're gonna talk about. And that I can't tell them the answers, but here are the topics. And we'll talk about what those are. That is what the heads exam is. That's your next slide, so we will go to there. Trying to make some sort of a relationship with this patient so that they trust you a little bit. So what are you doing? Well, you're not going to be judgmental. You're not going to lecture them. You're not their parent. You're not their aunt. You're not an older sibling. You're not a mentor. You are their healthcare provider, meant to give them risk stratification and medical advice. Similarly, if you feel uncomfortable, so if you've ever been around teenagers, they're very, very weird beings, very strange creatures. You might be very uncomfortable with them. Do not give up. Do not try to pawn this off on other providers. Do not be like, I will trade you 2 hypertensions for 1 teenager, right? You're not going to do that. You're not going to give up. You're going to persist and be really good at these adolescent interviews. When you're going through this, down the second part of this flow chart, it's really focusing on their highest risk behaviors and what they care about. So if they care about acne and sports physicals and all of their different, whatever it is that they care about, that's what you're focusing on. You're picking 1, maybe 2 different topics, the highest risk ones and specific to them. And then always with the touchy-feely, a lot of empathy, a lot of interest, a lot of understanding. Remembering it's hard to go through adolescence, those transformer years, very difficult, having as much compassion for that as you can. So this is the heads exam. The heads exam is functionally a glorified social history for an adolescent. So when we are doing our peds lab, when we are doing some of this, if you have an older child, this is how you will collect a social history. If you go to your rotations, a lot of times the newer preferred way is to do the shades exam. So they just took all the letters, rearranged it, added an S, and so the first S is now strengths. So you're starting with something positive. But if you're like, we were taught heads, and they do shades here, it's just Scrabble. Okay, so when we're asking this, so H is home. So something very non-invasive, or kind of invasive, but just safe, right? You're asking, who lives at home? Do you have 1 home? Do you have 2 homes? Do you have your own bedroom? Do you have a place where you can chill out and relax? So you're asking about their home environments. For their E, you're looking at education. Do you go to school? Are you homeschooled? Do you do a hybrid school? What grade are you in? What kind of grades do you get? So if you ask somebody, do you get good grades? What is the child's response? Yeah. No matter what their grades are. So to be very specific with these concrete thinkers. Do you get A's and B's? B's and C's? C's and D's? D's and F's? You just give them all the options so that if they're getting D's and F's, they feel comfortable to tell you. Do you know what you want to be when you grow up? If you have an older child, do you have plans after high school? What are you thinking about doing? So those are all those questions for your social history. For your A, I actually learned it with 2 A's. My first A was activities. What do you like to do? What do you do for fun? Most kids will sit there and stare at you and they'll say, nothing. And you say, I literally look back at them, I say, so you get home from school and you just look at the wall, stare at it? And they're like, well, no. I'm like, what do you do? You play video games? You go on TikTok? Like, what do you do? And then they start talking a little more. But they always tell you their grades are fine, they do nothing. Everything's fine. The next one is A for alcohol. So I usually start with asking about their friends. Or have you ever seen it? Have you ever seen alcohol? Does anyone bring it to school? Do you have any of your friends tried alcohol? And then I ask them about themselves. So not to lure them in, but to get them kind of comfortable. So it's really interesting if they're like, yep, I see alcohol, yep, they bring it to school, all my friends drink. And then if you're like, do you? And you're like, nope, right? So that doesn't make as much sense as a provider. It's not able to risk stratify. Very similar with drugs. I usually ask, what drugs do you do? Right? To throw it out there so that they feel comfortable to tell me. If I say, do you do drugs? They're gonna be like, mm-mm. Even if they are. If I ask, what drugs do you do? The ones that aren't taking any drugs will be like, I don't take any drugs. And the ones that do will start listing them off. And that is a wild conversation. When you have to write them down and go look it up later of what they're even doing.
MDMA.
That's a day. But asking them about that. Vaping is a huge one, especially how much are you vaping? The amount of, when Juuls came out and kids were doing, I don't even know how many pods, that was a wild time for all. Diet, some of that, do you feel like you need, do you want to lose weight? Are you wanting to gain weight? Are you trying to lose weight? Are you trying to gain weight? Can give you an idea of what's going on. Is there food insecurity there? And then we get down into the S's. So I learned safety, sex, and strengths. So they put the first strengths in front. The other thing that we'll ask, so safety, do you have a driver's license? Do you wear a seatbelt? Do you, any other high-risk activities that you do, or do you horseback riding, are you ATVing, or what are you doing? Sex, rather than just asking, are you having sex? I ask several different questions. Do you think that you are a boy, a girl, both, or neither? Do you like boys, girls, both, or neither? Do you have sex with boys, girls, both, or neither? Do you have oral, anal, or vaginal sex? When was the last time that you had any kind of STD testing? Are you on anything that helps prevent pregnancy? If you ask a child, do you use contraception? What do you think they do? And then you say, what is contraception? And they're like, I don't know. Right, so ask what you need. Help them out. Help them give you the information you need. Suicide, so you can do the standard, do you want to hurt yourself or others? I say, how many days a week do you feel down or depressed? If your mood was the weather, are most of the days sunny? Are some of them cloudy? Is it thunderstorms all the time? How do you feel? And then strengths, that's not one in there, but that is a heads exam. So when we practice that, that is a true full adolescent social history to be able to see, is this kid at risk for being bullied? Are they at high risk for STDs? Is there a risk of nutrition? You can figure out where to risk stratify them and where to intervene. Quick plug in that knowing your state laws are going to matter. So I know some of you are guards, some of you are reserve. You're going to be practicing in different states. The different states have different laws for how you can treat an adolescent. Federal law is going to trump all of that. So we have different federal laws if you are going to be in active duty or if you are on Title X orders. What that means for us, just for federal law, is that if you have a child over 14, you can treat them independently of a guardian for reproductive health, for STDs, for mental health, or for pregnancy. So if somebody comes in and says, I want birth control, or I am pregnant and I need XYZ, you can absolutely treat them. If they come in and say, I am pregnant and my arm is broke, you can treat their pregnancy-related things, you cannot treat their broken arm. They're separate. So, just to be aware for those. When we start looking at puberty, so we've gotten past the generalities, now we're looking at these kiddos. We're starting with the females. So puberty, and this should be a good review for women's health this week. So puberty, onset, should not be before the age of 8. That is when the brain is going to turn on and say, oh, now it could be time for puberty. And by brain, I mean pituitary. That is when pituitary gets the signals from the hypothalamus to say it is time to start puberty. Average age is going to be 11. So 8 to 13. 8 is great, 13 too late. 8 is great, 13 too late for females. It's considered precocious puberty if you have true puberty. We'll talk about what true puberty is before the age of 8. So you've heard Tanner staging. The true and most current and updated nomenclature of that is SMR stages, so sexual maturity rating. So people will use those interchangeably, or we use SMR rating, but that's the same as Tanner staging. So your true puberty, meaning the pituitary has said it is now time for a female, is breast buds. That's the only thing. You know, any other changes, none of them are from the pituitary other than breast budding. So true thelarchy is your SMR2 first change. Adrenarchy or pubarchy is going to be also in the late stage of SMR2. That is not true puberty. You see that alone without thelarchy. 3 or 4 is when you start to get the growth spurt for your adolescent females. That is always prior to when they start their menses. Menses is the very last event. So at the very, very end is when they have that. That will be, then they are in SMR5. Growth is functionally done and they are physiologically an adult female. So when you start to, when you feel breast buds, so the very first well visit or first time that you are like, there are breast buds, pituitary is turned on. And then they say, well, when are they going to get their period? About 2 years. So that whole process takes about 2 years because we're in peds, so guess 2. They will literally or usually only grow about 2 centimeters once they have menses. So something to watch for that growth chart. So if she is still 4'7" and she's in SMR3, you don't have a whole lot of time before those growth plates are going to fuse. So making sure you're watching those pretty carefully. Is she going to be tall enough to drive a car, to see over a desk, to use normal counter heights, things like that. So being aware of that growth spurt. Completion from start of the pituitary turning on until menses and you are in SMR5 is typically anywhere about 4 years in length. I've never seen a pants that didn't have an SMR question on it. So there will be an SMR question somewhere on your test, male, female, somewhere. And functionally it's like the APGAR where we said there's going to be a learn 1, learn 5, and the questions usually come in the middle. Right? So if you have SMR1, prepubertal, no puberty changes have started. SMR5, adult female. So 2, 3, or 4 is where the changes are really occurring. 2, thelarchy, breast bud. It's really what you need to know. So that's what's going on. 3 is some enlargement. There's really no difference in the areola compared to the rest of the breast tissue. And 4, the way that I have seen it tested over and over and over is mound on mound. Mound on mound breast tissue. What does that mean? It means you have a difference from the areola compared to the rest of breast tissue. So you have mound off the chest, second mound being the areola. So if you hear mound on mound, that is what they're referring to. If you're looking at pubic hair, number 1, I don't even know why your textbook didn't put a picture, but that is prepubertal, so nothing there. 2 is going to have sparse and very fine pubic hair, very straight. 3, it starts to become more coarse, more curly. It's still not adult hair quite yet. 4 is adult hair, but not adult distribution. 5 is adult hair and adult distribution. Okay. If you don't like the pictures in those words and you would rather learn them in a chart form, this says the exact same thing. So again, prepubertal, for 1, breast buds, the start of pubic hair. 3 is that enlargement of breast tissue, more coarse, more curly. 4 has adult-like hair and mound on mound. 5, you are full phenotypic female, adult female. How about for boys? So you get some of those earlier indicators before you actually get true puberty. So those early indicators, your deepening of your voice, facial hair, some of that peach fuzz, you might see an acne before you actually have true puberty. Where are those hormones coming from then? What organ? It sits above the kidneys. Your adrenal glands. You're getting those male hormones from your adrenal glands that are putting some of those early puberty signs before true puberty. So for males, True puberty happens when there's testicular enlargement. So that is when the pituitary turns on to say it is now time for these little boys, the testicles will enlarge. Nothing else is actually true puberty from the brain. Their age is a little bit higher. So most of the time it's going to be 9 to 11, but their age range is 9 to 14. So 9 is fine, 14, that's mean. Okay? As opposed to girls, that was 8 is great, 13 too late. So testicular enlargement, testilarchy is in your SMR2 stage. Adrenarchy is a little bit later, where you start to get some of the increasing development, more of those male hormones. Those later growth spurts are happening at a later range. And a quick note here in kids, so you guys haven't had chemo yet, have you? Haven't had it? So one of the signs that there's increased bone turnover in adults, and you're like, oh my God, where's the cancer? Is if your alkaline phosphatase is high, but that is a normal variant in a growing child who is growing and has bone turnover. So just a quick plug for there. And then scoliosis, particularly in young men, will worsen as they have these really intense growth spurts where their spine really isn't even catching up yet. The same thing, SMR stages here for males. Number 1, prepubertal, so you have no increase in testicular or penile length. 2, no changes in penile length or girth, but you have that testicular enlargement, so true puberty, SMR2. 3 is when you start to get increase in the penile length. 4, even more of that, but really not the breadth yet. And then 5, you get the full phenotypic adult male in length, breadth, and size of the testicles. Same exact pictures for pubic hair. 1 is going to be prepubertal. 2 has that the very fine and straight hair. 3, more coarse, starting to curl. 4 is your adult hair, not adult distribution. 5, adult hair, adult distribution. So there will be something about can you click out of SMR stage, and the reason being is that that's going to help developmentally, and it's going to be on your pants. Clinically relevant as well. If you like studying in chart form better, totally fine too. So that normal male, first thing, true puberty, testicular size. I cannot emphasize that enough. Testicular size, SMR2. Then their pubarchy from their adrenal glands to true pubarchy. Then penile length growing. Then that peak height velocity. I had a good question a couple cohorts ago. They said, when do they start making functional sperm? And it's in SMR4. So just like at the end for females, at the end for males as well. Their progression, a lot more for males, can be a lot more varied. So anywhere from 2.5 years all the way up to about 5 years. And I think this chart is kind of interesting, just comparing males to females. So really looking at what's happening first and what's happening at the same time. So menarche for girls, again, you're seeing at the very end. That growth spurt is at the end. You see the breast development and pubic hair development along the way. Versus males, where you see everything's just taking a little bit longer. But I for some reason particularly like this. I'm not going to put it on a test, but just helped conceptualize it. And before the entirety of your souls leave your bodies, I think we'll cut it off here so you guys can go study or go